Recently, the healthcare professionals from around the country gathered at the St. Leon's Armenian Church of New Jersey for a one-day conference titled Improving Healthcare in Armenia. Can the diaspora do better? The conference was organized by Kim Hekimian, Ph.D., and Shant Shekerdimian, M.D., M.Ph., and was sponsored by the Armenian American Health Professionals Organization, APO. This is the third year in a row that APO has sponsored a conference aimed to look at how the diaspora can move away from humanitarian assistance and towards institutional capacity building in healthcare in Armenia.
You guys can hear that echo, right? He holds a degree of a doctorate degree in pharmacy and as well as an MBA, and he has 3 children, and his wife is from the New Jersey area, so we are lucky because that means occasionally he will get to this area and continue to participate in our discussion. I think, do you know about your diagnosis? Why should you be stressed out and all that? And so we can't take our Western patient Bill of Rights. I mean, it should still be a Bill of Rights. The medical school and at the Institute of Human Nutrition. And we have had these discussions for a couple of years. Today we have...
The event began with welcoming remarks by Dr. Kim Hekimian and introduction of participants. Since the earthquake, the diaspora has spent millions and millions of dollars sending equipment, medicines, building hospitals and clinics, and yet the profile of life expectancy and the rate of premature death has not changed much, said Dr. Kim Hekimian in her opening speech, and then raised the question, how can the diaspora better spend its time and money to improve healthcare quality in Armenia?
Today we have the conference title is Healthcare in Armenia, Can the Diaspora Do Better? And the genesis or of this idea is that we know as a diaspora we have spent millions of dollars in Armenia over the last 25 years since it's become independent, actually longer than that, since the earthquake. Many of us in the room go over to Armenia and do projects and training, and the question is whether or not there's some kind of measurable outcome or impact from all of that input. And if there's not, why is there not? And if there's not, and we can sort of strategize about that, the question arises, can we do better?
The conference started off with Shant Shekerdimian, MD, MPH, a pediatric surgeon in UCLA, describing the burden of disease in Armenia, which are the diseases that cause the most disability, death, and premature death in the country today. As many are aware, 93% of all deaths in Armenia are from non-communicable diseases, with heart disease, cancer, diabetes, and respiratory illnesses leading the list.
Why should we focus on non-communicable diseases? Well, it's huge. The issue of non-communicable disease and the burden that it has on healthcare systems in general is pretty big. So the 4 major non-communicable diseases in the world, which are going to be cardiovascular disease, cancer, respiratory issues, and diabetes, account for the vast majority of disease burden in the region at large surrounding Armenia. Economically, it's been estimated that the loss of productivity due to this is quite significant. For every 10% increase in mortality from non-communicable diseases, growth of the economy is reduced by 0.5%. In Armenia, non-communicable diseases account for 93% of all deaths. So again, this ratio is flipped in other parts of the world where infectious diseases such as HIV and malaria predominate. That's not the case in Armenia. Armenians, actually, when you compare them to other former Soviet republics, live longer, but they do so in poor health, and that's because of non-communicable diseases. The disability adjusted life expectancy in Armenia was 63, and for men, and 59 for women, whereas the life expectancy is 71 years. So imagine this. So 8 years of life in Armenia is spent in disability. So they are alive, but they are not productive contributors to society. They are unable to function in terms of their work and providing their family for their families, and this is all due to non-communicable diseases. Armenia has a high burden of non-communicable diseases and one of the highest rates of premature mortality in World Health Organization European region, which includes not just Europe, but the Central and Western Asia countries that surround Armenia. The premature mortality rate, and we'll talk about this a little bit more because it's quite significant in Armenia because of the four major non-communicable diseases, was 470 per 100,000 population, which is well above the European average of 380. The life expectancy of in Armenia is 72 years, 71 point something, which is below the regional average of 78 years. And this is, again, largely because of non-communicable diseases.
The second speaker was Samuel Badaliad, MD, a urogynecologist in Syracuse, who spoke about women's health issues in Armenia.
Let's look at the numbers of maternal death in Armenia. 31% is pre-existing conditions. We have a severe bleeding, hemorrhage. And I don't think so in this time, in this age, people can die because of bleeding, postpartum bleeding. And everything can be done to stop it, all right? Women not supposed to die because of hemorrhage. And in Armenia, this has happened very often, particularly in Marzer. And I'm going to tell you why this is happening. And, even numbers comes 31% pre-existing condition. I don't think so this is the right, pre-existing condition, like they're going to call mom died because of anemia, not because of anemia. She died because of hemorrhage, her blood count was low head before that, and they're calling anemia is cause of her death. All right, which means this depends how you put the numbers together and depends how you go forward. You have to, again, accept the hemorrhage is #1 killer in Armenian movement, and hypertension, eclampsia is the other ones. If you look the countries around the CIS countries, again, #1 is hemorrhage, 27%, which means Armenia is sitting the same. They're trying to classify differently in order to not to face that issue. How can be prevented? It's if you think most efforts until now or until recently were completely directed to the sending specialists from Yerevan to the Marzer. If it's any emergencies was happening somewhere, it was someone was calling to the Yerevan hospital. He sits in a car driving 4 hours, 5 hours to go to the Mars and see what they are doing. The woman hemorrhaging there 4 or 5 hours when he's driving there. And the people there sitting and waiting, someone going to come from Yerevan to solve their problem. When he comes there, or the woman is there, he cannot transport this patient back to 5 hours because he's afraid the woman going to die on the way to the hospital. Let's see what we can do here. And then all of them sitting together and watching how this poor woman is dying from the simple conditions, all right? Because she needs the surgery, she needs hysterectomy, and none of them are qualified to do surgery. Or this new doctor who came there, it's already too late, he's afraid to take, and they're going to blame him why this happened, right? Which means those are the typical scenarios which was happening there. Residency program. I think if someone going to ask me what is the most important thing for Armenia, what you can do, we need to change our residency program, not only in OB, in every specialty. If you're not going to do this, if you're going to be able to do this today, after 4 or 5 years, you're going to have qualified physicians. And number is not important. The quality of the physicians is important. Right? They need to know what they're doing, how they're doing, and the steps, how they follow protocols, how they do. All right, what's happening right now? All our residents paying to Yerevan State Medical University to do resident. They paying to the university. Which means Yerevan State Medical University hiring so many residents without knowing how many residents can be trained in certain hospitals. All right? They don't consider how many delivery C-sections there. They put 10 residents in one hospital because they make money, more residents they're going to hire. Those going to the hospital, they don't care how many are there because they don't do it. They're just writing the medical records, all right, handwritten. They don't do surgeries, they don't do it. They just watch something there, sometimes assist there. I sent the curriculum for residency program to Armenia about 10 years ago. I sent that every resident have to do 180 C-sections. When they changed the number, it was like 2 or 3 and assist 10. So why are you doing this? Because we don't have enough numbers. Listen, you don't have enough numbers, cut down your number of residents, all right? You don't have numbers, you don't get residents training because you don't want to train unqualified people there. This is tragedy. We never can talk about women's health without talking about cervical and breast cancer. Those are actually big problems. And if you look, Armenia, 1.18 million women, age 15, and every year in Armenia, 115 or some patients, some people say 150 women dying from cervical cancer. Even you ask GYN oncologist Gagik Bilazegan, he says 300 cases cervical cancer, 150 are dying every year, which means number is same last 20 years, all right? If number is never changes, always the same number, doesn't matter how you talk. They already know every day the same number, 150 women dying. What can be done? If you look the numbers with Armenia, you see breast cancer huge, 100, 102. Cervical cancer, it's a sixth killer, 16.4. Breast cancer followed uterine cancer. As far as I'm concerned, from uterine cancer, nobody's have to die. Maybe such a low number, because it's easier to diagnose endometrial biopsy and do hysterectomy grade 1, grade 2, and done. All right? In Armenia, people dying because of endometrial cancer. This is scary. This is, again, knowledge issue, medical training issue. They don't know how to do biopsy, which cases, how it needs to be done. Cervical cancer, it's a pap smear issue, all right? It's a screening issue. Breast cancer, mammography, screening issue, which means those are things which you need to look. HPV vaccination, all right? I'm not going to go to the big discussion about HPV vaccination because I'm sure all of you know what's happening in Armenia. Even government's trying very hard. Even a week ago, Minister of Health gave him HPV vaccine on the live TV. Minister of Health, he gave it to him himself, right? Because people, they don't trust the vaccine. They consider vaccine was artificially brought to Armenia to decrease the fertility rate, to make Armenians infertile, to decrease our number of Armenians in the world, to kill, to create some disease, to experiment. It's a lot of public forums. If you go on the internet and read what they're writing about against HPV vaccination, you'll be shocked. So how we can improve women's health? I think discipline, hard work, and I think we need to go forward together, Armenian diaspora together. We need to be able to contribute to society, all right? We don't want to criticize, I think we need to look forward in order to make some changes and make Armenians happy. And I think this is the key.
Kim Hakimian, Ph.D., assistant professor at Columbia University Medical School, finished the morning session with a discussion about how we define institutional capacity building and showed slides from the Lancet series in December of 2018, which discussed how more people die worldwide from poor quality healthcare services than do from the lack of access to the services.
There's a great difference between what somebody knows how to do and what somebody actually does. And we have that problem globally. So, again, we are not in the room to be pointing fingers at Armenia, but also to point them at ourselves. And what we know to do, we don't always do. So what could we do to close that gap in Armenia, and not only measure with knowledge, but even if we were just measuring knowledge, that would be a great increase from what most people do now, which is not take any pre-post information on the interventions that they do in Armenia.
After the break, Larry Najarian, MD, ophthalmologist in New Jersey and president of APO, reviewed the various and numerous diasporan organizations working on healthcare projects in Armenia.
But how did it all start? It all started with the combination of an earthquake, independence, and a war with Azerbaijan. And the first really major humanitarian effort has just been really understood. It was by a humanitarian named John Samurian, who was in Boston listening to the news about the earthquake, sitting there in front of the TV asking, what can I do? He was a Harvard football player. He immediately called up one of his Yale competitors, and that was Vernon Luke, who happened to be the chairman of Baxter International, who happened to have all the dialysis machines in the United States, and said, what can we do? And he said, let's ship them over. They had one problem. It was Russia and the United States in the midst of a Cold War. So Ted Kennedy actually intervened in a very quiet way, and this has just come to the forefront, where he actually talked with Russia, and they allowed the first major shipment of humanitarian aid to arrive in Armenia. So that was the triumvirate that got it all started, and since then it's been off to the races. In the New York area, we are very, very grateful to one of our former members, one of our award winners, Dr. Edgar Housepian, who was just an amazing example, who led the first medical mission after the devastation in 1988 and created Fire Fund for Armenian Relief, which to this day is involved in infrastructure building and healthcare. The medical outreach for Armenia, we're very, very fortunate to have this program started. This was an amazing effort. It has a great impact on me personally. This was done by a philanthropist in this area, Arthur Halvasian, and behind every great man there was a great woman who just happened to come in, and I had no idea, my Aunt Alice Movsesian. But this was a tremendous program. They actually brought children here for surgeries, heart surgery primarily. I had the benefit of being involved in one of those cases, which I'm still involved with to this day. There's a host of Armenian organizations. This is just the New York area. It's the whole alphabet, and we're just going to run through what they do. the Armenian Missionary Association. Healthcare is not their primary focus. They have a member of their church who's very, very hardworking with his wife. They've been doing medical missions to the same area in Armenia and have set up a clinic. They also have the Ainilian Medical Center in Yerevan, which was again put up by a donor, it's active and working to this day. And they're based here. The Genetian Foundation, we're very happy to have a representative here. And maybe I should just ask you to tell us about what the Genetian Foundation is doing in healthcare.
We are involved in healthcare for 50 years in the Middle East Armenian communities and in Armenia since independence. And that was a great pleasure for me today to hear words like education, systematic change, infrastructure change, because that was what we're trying to address, sometimes alone, sometimes with the Ministry of Armenia, changing introducing development projects versus charity relief. One of our famous projects is training of village nurses all over Armenia, Nagorno-Karabakh, focusing on preventative healthcare services, improving access to the high quality healthcare services.
Aline Bagdasaryan, MD, MPH, Pediatric Emergency Room Doctor in Virginia Commonwealth University, has worked with a team of pediatric emergency doctors in Armenia on a series of trainings over the years, and she collected data to show the change in the knowledge, attitudes, and practices, and has published this data.
So the survey study looked at the needs assessment, knowledge, skills, and attitudes of those physicians about pediatric emergency care. We had 80% response rate to the survey, and we had part of this survey was a 10-question knowledge test that tested their basic pediatric advanced support skills, such as CPR, compression ventilation ratio, when to intubate a patient, what is a neonatal resuscitation, kind of basic, how to do epinephrine, those tests. And so some people had said that they had some postgraduate pediatric education and some had not. So in blue are those who had received pediatric education postgraduate, and in green are those that had not. However, so the passing score for this test was 70%, and if you look at the majority fell below 70%. So the majority of the participants, regardless of whether they had received pediatric education in the postgraduate setting, did not pass this knowledge portion of the test. At the same time, and very reassuring to us, was that they agreed that the pre-hospital pediatric emergency care guidelines would make care more effective, and this was the majority of them, blue and green. They agreed that pre-hospital PEC-related education needed improvement. They agreed that knowledge from our system, so the Anglo-American culture, could be beneficial to medical advances in Armenia. And they also agree that there is need for a specific CME, pediatric-specific CME for pre-hospital care providers in Armenia. So green and blue again. So this was the majority's perception. So this was my cue to say, well, we need to do something, and we can, because there is acceptance to it. They also addressed some of their barriers, part of the survey, and they identified that they needed more equipment, medications, knowledge and skills. They needed to know pediatric medication dosing. Their challenges were multi-trauma or severe TBI cases. They were worried about the family's intervention and care when they went to the houses with the ambulance, that the primary care doctor would interfere, that some of them said there was no pediatric-specific ambulance. There was no pediatric specialists because they were not trained to be pediatric specialists, and they're physicians, they're not paramedics, so they have not received this in their training from the very beginning. They were worried about inappropriate EMS system and the process of transition to the hospital. For example, there is no transfer of care. A simple thing that we do every day when you have to transition care between physicians did not exist to them. So they would come to the hospital, drop the patient off, and there was no transfer of care that happened there. That 3 minutes that we have to be quiet as emergency providers when the paramedics bring the patient, that doesn't exist.
Nika Haratunyan, MD at UCLA, then spoke of the data she collected recently about Armenians' attitudes and perceptions about cancer screening, colorectal screening in particular, since Armenia has a very high mortality rate from colon cancer, since people get diagnosed in late stages.
We don't know much about what patients' knowledge, beliefs, perceptions, barriers are to getting the screening done in Armenia. And so we aim to evaluate this. The methodology that we used was actually working off of population representative cluster sampling, and we worked in polyclinics, decided to focus across those polyclinics in Yerevan. We administered voluntary surveys based on the health beliefs model, which actually looks at all those things that I talked about: knowledge, perceptions, barriers, and cues to action. We looked at a fair number of barriers, but these are the few that I chose to kind of bring to this presentation. And regardless of the fact that the previous mentioned results that I talked about, most still didn't think that it was necessary to get screening. And perhaps the thing that resonated with me the most as someone who's going into primary care was that only 7% had reported having had their provider discuss colon cancer screening. Very few patients were counseled on screening by their physicians, and while most patients expressed willingness to undergo the screening, they'd only do so if it was free. This was kind of the first part of our project, and we hope to take this many steps further, and we hope that this can be useful in developing organized screening programs in Armenia as well as other lower middle income countries. I think we should really focus on raising awareness, effectiveness of screening, thinking of marketing campaigns and how to get people to really understand how effective screening can be. And then I think we have to face the realities and understand that nothing's going to happen unless costs are low and or subsidized.
Lastly, Lorki Libaridian, MD, who is both a pediatrician and internist in Boston, spoke of her work developing pediatric training for medical residents in Armenia.
Working in the villages, we said there really is a need for pediatric training in family medicine docs in the villages. So we had gone out, and I think I talked to Kim and Shant about this years ago. We know that growth charts are not getting filled out, or they're getting filled out in really inappropriately or in a spotty way, or not being filled out well, that the hemoglobin screening is not being done, that they're stunting. But so we went out, we were out in the villages, and I think I looked at 200 charts, and Antonian, who is one of the amazing docs at COAF, looked at probably about 200 charts. So we looked at hundreds of charts. And I don't have the numbers with me, but the vast majority of charts either were not filled out or were filled out really spottily. And as you had pointed out earlier, one of the main things we do in pediatrics is prevention, or picking up disease. So how do you know if a child is stunted if you're not filling out the growth chart? So these are just a couple of pictures just of the small groups and being interactive. I actually had them measure each other's heads. A lot of the docs aren't used to actually measuring heads anymore. The nurses do it. So seeing that there is variation and that it's important to actually try to get the right measurement. I had them 3 people measure one person's head and then discuss the variation in results. We had them I gave them cases of numbers. They had to sit down and chart, and then on the growth chart and then diagnose it. So you see one of the women is actually holding up the growth chart and trying to say, I think that one was a case of constitutional delay of growth, and trying to decide when do you refer and when do you not refer. So that's always an interesting question, because you don't want to be over-referring, and you don't want to be under-referring, and it's always a fine line, and it's never perfect.
This was followed by a panel discussion where 3 diasporan Armenian American physicians described the work they were doing in Armenia and how their work is meant to improve quality of services and how it is measured with evidence-based surveys. At the end of the day, a word cloud poll was taken by the participants with the question, "In one word, how do you feel about today's conference?" In addition, conference participants were asked what were the key takeaway messages from the day, and they mentioned emphasis on prevention, capacity building, medical education, data collection, quality of care, sustainability of programs, evidence-based approaches, collaboration with local stakeholders, mutual learning with Armenians. The conference ended, but the work of Armenian health professionals continue to improve health care in the motherland of Armenia.